So it's an algorithmic approach to fitting an additive model comprising many small regression trees. Now, I know many of you are familiar with TreeNet, so I'm going to try to sort of walk a line between reviewing enough of how this works without reviewing too much of how it works. But some may have not looked at this for a while or ever at all, and so I think that I need to provide some background. And so when I read Dr. Friedman's series of papers, it was clear that, or it seemed to me, that this approach is quite well suited to risk adjusting cost predictions. It assumes that the target variable or response or outcome variable, dependent variable, all being the same thing, is continuous. And this works well in situations where there are only a small number of patients with zero costs. If you have a lot of zeros, then other approaches have to be considered. It accepts categorical and continuous predictors. It can efficiently handle a very large number of predictors. And it can model these higher order interactions, which is what we're interested in, up to, say, even 12-way, if it turned out that 12-way interactions among diagnostic groups are informative. And so the algorithm, essentially, one can think of it sort of exploring the data systematically, looking for important interactions and incorporating those into a fitted model. Now, in thinking about how this procedure might solve our problem of trying to identify these consequential interactions, it's helpful to have a sort of a regression tree in mind. And so this is the first of 232 trees from one of the models that I fit, and I will describe that shortly. The CCS refers to clinical classification software. So CCS 158, for example, is the diagnostic category chronic renal failure. 0 and 1 refer to present and absent. And then you can see there are other variables where splitting occurs: age, region, other demographic variables. So the tree basically divides the sample space into, or population space, into disjoint subsamples that are defined by combinations of the splitting variables in the boxes and values on either side of the split point. And then assigns a coefficient to each of these disjoint regions of the space. Now, this is the first tree, so in essence, this is saying that the predicted cost is equal to the dollar value coefficient at the bottom for, so for example, here, CCS 158, so we have a patients with chronic renal failure and hypertension with complications and acute renal failure also on top of chronic in a region other than the South have this predicted cost. So you can see that the individual trees do incorporate main effects and interactions, admittedly in a way that makes it hard to separate a main effect from an interaction, but is able to incorporate both main effects and interactions. And the maximum number of interactions that can be represented by an individual tree is equal to 1 minus the number of terminal nodes, which in this case was 12. This tree was fitted with the aim of stopping when 12 terminal nodes had been achieved. And this slide just summarizes some of those points and also emphasizes that the trees in TreeNet or with the Friedman algorithms are fit in the best first strategy, which is a greedy strategy. So starting at the top, one makes successive splits of the sample space at each step to increase maximally the fit between observed and predicted costs. So for regression tree boosting, or TreeNet with tree type equal regression, this slide tends to just sort of outline the overall approach of the algorithms. They start by initializing predicted cost for all observations at the mean or median cost in a training sample, and then fit sequential trees. And at each of these steps where a sequential tree is fit, begins by computing the current residuals, taking the observed and predicted cost, and fitting a tree to those residuals in the training sample using the best first approach, fitting a tree along the lines of what we just looked at. And then updating predicted cost in each observation by adding a fraction of the terminal node coefficients from the fitted tree, the appropriate terminal node coefficient to each observation. And in this way, the predicted costs gradually move closer to the observed costs. The closer they get, the smaller the loss, the better the fit. And so here I've indicated that I often use the term fit, sort of because the way I was trained as a statistician, I tend to think of fit rather than loss. Sort of the opposite of loss, if you will, is the overall closeness, depending on how you decide to measure closeness, of predicted and observed values. So the final model is a sum of contributions from many trees, and has been referred to as multiple additive regression trees, or MART. So turning to the example that I'd like to present, the data source is the market scan database, which you may or may not be familiar with, maintained by Thomson MedStat. It can be leased for research purposes. It has claims and demographic data for health plans of 45 private and public employers. All states are represented. I include claims for and demographic data from members under 65 because the Medicare data was not in here, and excluded members who didn't have a claim in 2001 because they wouldn't, therefore, including them would have would have inflated the predictive capability of any model that I developed, since people who did not have a claim would not therefore have diagnoses. It would be sort of circular prediction, if you will. And so the dependent variables or targets for model fitting were total paid cost, including pharmacy and member liabilities, in 2001 and 2002. Predictors are 260 indicator variables representing the diagnosis categories from the clinical classification software. These indicator variables were assigned for each patient. So each patient had 260, 0 or 1, assigned based on their claims for face-to-face clinical encounters. So these are assignments of diagnosis categories based on 2001 claims to predict costs in 2001 and in 2002, both concurrent and prospective. We also had age and gender, region of residence, and number of months enrolled. This is the top part of the table from a published version of this research, and shows that the costs are predictably higher in the indemnity than PPO and POS plans. Patients tended to be older in the indemnity plans. Mixed refers to patients who changed plans during the year. So these are sample characteristics stratified by plan type for based on 2001 plan enrollment. This is the bottom half of that table. And what's, I think, important here is just to note the number of diagnosis categories per member. And so you can see that about 20% of members in all of these plans had diagnoses in 6 or more diagnosis categories in a given year. So there's a real potential for interactions to be important. So it seemed to me that costs really represent different quantities in the different types of plan basically because of contractual agreements between providers and payers. In essence, a dollar will buy you less in an indemnity plan than a PPO, and even less than, say, an employment service plan with an HMO, but it's primarily an HMO with an out-of-network option.